So here's the anatomy of the deep neck flexors. So the pharynx and the other superficial structures of the neck have been removed, and we can see the vertebrae, anterior part of the vertebrae. We have the longus colli muscle here, and then here we see the longus capitis, and it's kind of a continuation in the serratus anterior. And then up here we have the small muscles of the upper cervical spine, the rectus capitis anterior major. So we can note that all of these give segmental control of flexion in the neck. Here we see a diagram of a muscle action relative to the cervical spine radiograph. We can see here's the whole cervical spine with the occiput, C1, C2, and then as we kind of come down here, we can see this is C7 with the long spinous process. Here's the mastoid process, and we know that the sternocleidomastoid muscle, which is one of the dominant superficial muscles of the neck, takes its attachment from the mastoid process and then inserts onto the clavicle. And we can see how it crosses the vertebrae. And knowing that the joint centers of each segment lie in the intervertebral disc, we can see that this muscle functions as an extensor of the upper cervical spine and a flexor of the lower cervical spine. So segmental control would have to come from muscles that attach to each segment rather than superficial muscles like the sternocleidomastoid. So Dr. Joel, a clinical scientist from Australia, has done a lot of work with the neck flexors and their importance for postural control in patients with neck pain. And we see one of her some pictures from one of her articles here where she's developed this test where the person lies supine and does cranio-cervical flexion, meaning like nodding your head yes, attempting to reverse the lumbar lordosis into a blood pressure cuff or a bladder, and then is watching the rise in pressure here on the gauge. And one of the key things that's happened is when you recognize, when you lift your head up as we're seeing B, you're really recruiting your superficial neck muscles like the anterior scalene and the sternocleidomastoid, which account for over 80% of the force it takes to perform this activity. So it's a very poor test of deep flexors or the segmental muscles that are helping you when you're sitting upright in terms of postural control and that kind of thing. So this test was developed, and the way it kind of works is the person reverses their lordosis and watches the rise in pressure. Now, initially you want to inflate the bladder to about 20 millimeters of mercury to fill up the lordosis, and then they exert an effort trying to increase the pressure to 30 millimeters of mercury. And then they hold each, for a rep, they will hold it at their target pressure for 10 seconds. And the reason it's so long is because they're trying to train the endurance of the deep neck flexors, not the torque output. So what's the validity of this approach? So does it matter so much that you change the way you're moving your upper cervical spine and that you're reversing your lordosis? Well, in this study, Dr. Joel really put that to the test, where they attempted to record the EMG activity from the longus colli and capitis by inserting a surface electrode down the pharynx and laying the surface electrode on top of the inner lining of the pharynx to get a surface electrical reading of the EMG through that lining. And what we can see is they have here's this graph of their data where they have the patients, which were healthy controls, performing the different pressure levels where they started at 22, 24, and then went all the way up to 30 millimeters of mercury. And then the EMG recordings are on the y-axis, and we can see that progressively increasing EMG activity as they perform this deep neck flexion task. This pretty much validated that the exercise itself is effective at recruiting and isolating in a progressive way the deep neck flexor muscles. Now, that's good because we saw how the EMG is affected by the exercise and controls, but does it really help patients with neck pain? And so here we see that in a sample of patients with neck pain, one group, this first set of graphs, performed the training as prescribed, and the other group didn't perform the deep flexion training and just did strength exercises. And what we're seeing here is the normalized EMG of the sternocleidomastoid muscles on both sides during a head lift task. We can see is that essentially the patients who just performed the strength training, there was essentially no real difference in their EMG pre and post. Yet the patients who performed the deep flexion exercises had dramatic decreases, with the post here being the open circles. Post-training had dramatic decreases in the superficial muscle activity of the sternocleidomastoid to perform the same task, suggesting that the deep flexor muscles were taking on a larger contribution of that task. They found similar effects for an arm raising task. So based on this research, Dr. Joles proposed in a 2009 article that's been widely accepted a progression of exercises for patients with neck problems for the deep neck flexors, starting with the very specific task here where you do a low load, pressure monitored feedback task to try to recruit those muscles and decrease the activity of the superficial muscles, and then you do a task that combines the deep flexors with the superficial muscles, and then here you do a higher load task where you're working the deep neck flexors while the SCM is stretched.